Good afternoon or good evening, wherever you're tuning in for this next edition of our continuing education webinar series. My name's Troy, and I'm the Chief Operating Officer of Nurses Specialized in Wound Ostomy and Continence Canada, and I'm delighted to be joined by an amazing panel today. We're going to be talking about barriers to care, advancing equity in Indigenous health. And before I introduce Bev Smith, who's going to take us through a little bit of an introduction, I wanted to remind everyone of a few housekeeping items. First things first, we're going to be having a Q&A session at the end of this presentation today. So if you have any questions, please do click on the Q&A button in your Zoom toolbar, and we'd be happy to get to as many as possible. We're also going to be recording today's presentation, so if you want to watch it again afterwards or share it with your colleagues, you'll be able to see that on our NSWOC.ca website within the next day or two. And we'll make sure to email everyone today with a certificate of attendance also in about a day or two, and that'll include the link to the recording as well. I see some people are already putting it in the chat, but if you haven't already, click on that chat button and let us know where you're tuning in from, and maybe what your relationship is to wound ostomy and or continence health. I would love to see where you're tuning in from. That's great. We got Nova Scotia, we've got Sudbury, we've got Regina, we've got Saskatchewan. Love to see everyone. So without further ado, I'm going to pass over the mic and the slides to Bev, who's going to take us through a little bit of an introduction. Thanks for being with us, Bev.
Thanks, Troy. Welcome, everyone. Thanks for joining us today, whether it's from the East Coast or West Coast. We're so happy to have you. My name is Bev Smith. I am currently the president-elect as well as the co-chair for the Indigenous Core Wound Ostomy Continence Core Program for NSWOC. Unfortunately, my other co-chair, Michelle Buffalo, couldn't make it tonight. She had some family emergencies to attend to, so she is not able to join us, but we miss her for sure. I'll start with doing a land acknowledgement. So NSWOC and the NSWOC Indigenous Wound Ostomy Continence Core Program respects and affirms the inherent and treaty rights of all Indigenous peoples across the land. We have and will continue to honor the commitments to self-determination and sovereignty we have made to Indigenous nations and peoples. We acknowledge the historical oppression of lands, cultures, and the original peoples in what we know now as Canada, and fervently believe that the collaboration to improve health care for all contributes to the health and healing and decolonization journey we all share together. So the next slide, I just want to talk a little bit about our core program. It's been around since 2018, and we have people from across Canada that have joined our program, and there's about just over 50, I believe, right now. And we have NSWOCs, we have SWANs, we have physicians, there's some pharmacists, patients, students, other health professionals as well. And we all have the goal to advocate for Indigenous people in the interest of wound ostomy continence. We have successfully been advocated to become prescribers with NIHB. That was one of our initial goals. So we had that for NSWOCs across the country. And we also successfully advocated to get negative pressure wound therapy, disposable, covered through NIHB as well. And then we also created a website. And this is, if you see on the screen, the website Sharing Circle. And there is a QR code. It's in the on the slide, and it'll be on the banner on the side as well, in case you want to click on it during the presentation and have a look at it later. But there's lots of information, and we have each province and territory there so that we can have individual things, because we know everything is a little bit different across the country. So we have a little bit of information for each area. And if anybody has any information that you'd like to share and have us post on there, you can send it to the office at NSWOC, and we will gladly look at it and put it up on our website. So yeah, that's our little website that we had developed. So for tonight, the webinar that we're hosting tonight is called Barriers to Care, Advancing Equity in Indigenous Wound Ostomy Continence Health. And our objectives for this evening are to identify common barriers with Indigenous peoples may face when accessing wound ostomy and continence care across different care settings, We'll reflect on real-life case studies to better understand how systemic, cultural, and social factors influence Indigenous clients' healthcare experiences. And we'll apply practical cultural safety strategies to help Indigenous clients navigate barriers to improve access to wound ostomy continence care. So we're so excited tonight to have three wonderful NSWOCs from across the country. They're here to share some stories about clients that they've had and some barriers that they had come across during their care. So we have Josée from Ontario, we have Amanda from Alberta, and we have Tina from BC. So now I'm going to hand it over to Josée, and she will start with our patient stories.
All right. Thank you, Bev and Troy, for the great introduction. So, Ani, welcome. I'm located on the traditional lands of the Atikameksheng and Anishinaabe and Wahnapitae First Nations. Both are signatories of the Robinson-Huron Treaty of 1850. So, like Bev said, I am located in Ontario, closer to Sudbury, Ontario. And I'd like to share a story from one of our community members. So I'll go to the next slide. So I'd like for you guys to meet Mr. White Loon. He's given us permission to share his story in terms of healthcare and also his clinical images. So we thank him for that. So, Mr. White Loon is a father of two adult children. He currently lives alone in a community that's give or take about an hour and a half away from Sudbury, Ontario. For fun, he likes to drive his side by side within his community trails. He also likes to kind of putt around his yard with his dog by his side. So, he's a great advocate of just being outside. Not only does he live a little bit farther away, but he also has access and is really close to his community and other communities around him. So he's a little bit all over, and he's a great. He likes to travel. Let's just say that. So I got involved in his care when his primary care provider called me in and said, "Josée, you need to come see this community member. He has a few wounds to his feet." So we're going to go to the next slide, please. So here's a little bit of his medical history before we get to meet his wounds, unfortunately. So he has type 2 diabetes that he's had for the last 20 years. He has a loss of protective sensation to his bilateral feet. So this is neuropathy that gets a lot worse during the winter months. He has mild hypertension. He is a smoker. He smokes tobacco. And like I said, he had multiple wounds to the plantar aspect of his feet. He also has a great support system, like I was saying. He has his support team includes individuals from the past and present, which are his traditional medicine practitioner, the vascular surgeons, chiropodists. He has a diabetic nurse educator, who's also a skin wellness associate nurse, a dietitian, home care nurse, personal support worker, foot care nurse, physiotherapist that's been offering offloading, and an NSWOC, which is myself. So as you can see, he has a great team working for him, but sometimes there's still barriers and we try to have to get over them. So let's meet Mr. Loon. So this is our first interaction. This was the first time meeting him. As you can see, maybe from the photo, you see his arms crossed. He really didn't want to be there. But his primary care provider did talk him into going to see the foot care nurse because she was very, very worried that, you know what, he'd lose his feet if we were not getting involved and trying to help this, our friend, Mr. Loon here. So, luckily, I was in a clinic where there was a foot care nurse that day, so she was able to do his foot care while I actually just sat beside him and started chit-chatting, which, if anybody knows me, that's what I like to do the most. No, I'm kidding. So ultimately, I was able to sit beside him and try to find out a little bit more what was going on with his feet. He said he's had these wounds for many, many years. They're only getting worse. And in the past, he's gone to see vascular surgeons. He's seen chiropodists and other members of the healthcare team. And they all said, do you know what? If you don't stop smoking, or if you don't start doing the wound care, or what he was doing with his traditional medicines, or if he, he had to make all of his appointments, and they kind of always told him what he had to do, and he never really got involved, and he kind of just said, do you know what? I kind of don't like this. And on his last appointment, when he saw his chiropodist, he was told that, do you know what? You're going to have these wounds forever. So do you know what? If you don't kind of do what we kind of tell you, you're going to have these forever. And that kind of just told him that, do you know what? Maybe this isn't for me. So he kind of decided to, you know what, I'm not gonna go. I'm not gonna go see them anymore. I'm gonna do my own thing. If I'm gonna have these forever, at least I'm gonna care for them the way that I want to, and I'm just gonna kind of live my life, go on my, quad rides and play with my dog and just enjoy life and continue on. Well, while I was there, he also then opened up about other things, right? So how our healthcare system made him feel, right? So like I said, he didn't want to go see them anymore. He never really felt good when he was leaving those appointments, and he always said he always got contradicted information. So by the time the nurse cleaned up his wounds, we can see here from the images on the left, he has a lot of callus buildup and whatnot, but then on the right she was able to clean those up, and then we noted that he had two of the wounds actually probed to bone. So this really gave me the opportunity to kind of explain to him a bit more about neuropathy, how we get wounds to the bottom of our feet, and then also kind of devise a plan that together, Mr. Loon and I can kind of figure out a way to start healing these wounds. So when we left that first appointment together, I made a commitment that I would meet him at his next foot care appointment, which was going to be 4 weeks from now, and that we would start looking for wound care. Unfortunately, where he lived, wound care sometimes takes a long time to kind of get started, especially as a new client. So we taught him how to do basic wound care, how to wash his feet every day, and ultimately we would meet again in 4 weeks and continue on our foot care journey together. So we'll go to the next slide. So I've seen him multiple times, but now let's fast forward to June 2025. So now in June 2025, as you can see, our wounds are getting much smaller, right? So for the last 3 months, we've been going to foot care appointments together. We've been doing appropriate wound care. We've been able to finally get wound care involved in his home to kind of maybe tweak some of the dressings or his technique as much as we could. And he also started, he was able to see some progress in his wounds, which was amazing, right? So it was easy for me to try to implement, let's talk about going to see our diabetic nurse educator, or let's look about nutrition and just bring in other aspect of wound care to try to support his feet. But again, we took these in baby steps. And I think it was because we created this relationship that we're in this together. At the end of the day, I will be here and we will be able to heal these wounds together. So I'm not saying this was always there was always a couple steps back type scenarios. But we were doing great. He was motivated. He wasn't missing appointments. He was even talking about possibly reducing his smoking, like smoking cessation. So this was great. I loved all of this. So anyways, he was doing great. And I think he knew where this was going if we kept up with this, right? So I'll go to the next slide, please. So this is in June. And now in November 2025, just a few months ago, our wounds are almost closed. So when I look at these wounds here, again, this is 5 months later. Within those 5 months, we were able to implement the Darko all-purpose shoe, offloading shoe, pardon. So some of his community members, the physiotherapists, were able to add additional felt to the offloading shoe to provide that plantar pressure redistribution. I can honestly say he's never missed one appointment. And the biggest thing is that, now he's talking about, well, when these heal, like what's next? Like he's just so motivated to, continue on. And I think this is where education and this trusting relationship really comes into play where, just because they're closed, it doesn't mean that we kind of forget everything we've just learned in the last few months, right? So we're looking at different types of footwear, bringing in other members of our healthcare team to kind of support him in a lot of these just more of resources for him in his community. But this was challenging because again, he lived about an hour and a half away to all of these appointments. So this was a really big commitment. And I was really happy that together we were able to do this together. So I'll go to the next slide, please. And I can honestly say the cool thing about this is that I saw him right before Christmas. And I'm telling you, we're so close to closing. Like he looks like fantastic. So I'm thinking that 2026, he should be closed. Fingers crossed. But let's talk about some of the barriers actually that he has been facing. And do you know what? Unfortunately, he still has to face kind of every day just because of where he lives ultimately. right? So the first one is trust, fear and trust. So he has mistrust of the healthcare system and fear of negative outcomes, right? So the racism. So like in the beginning, like I said, he had these negative experiences with multiple members of the healthcare team, right? So he often felt that he was being talked down to and wasn't really part of his healthcare, journey. Ultimately, he didn't really have a say. Um, he also said there's fragmented care, so poor coordination between foot care nurses, the chiropodists, and also home care. So he felt that there was a lot of appointments, right, that he had to attend, and maybe the chiropodist would change the order or the foot care nurse would change the order. And again, he always felt like he was getting in trouble. And he was kind of the one just always, oh, I'm doing what I'm told. I'm trying to, attend everything. However, I'm always getting in trouble. So again, that was an option where he kind of decided like, I don't really want to continue with going to see these types of healthcare providers because again, I don't feel good when I leave, right? We also had other barriers which are logistical barriers, which is more transportation to and from appointments. So because he lived in a community outside of Sudbury, where a lot of our larger centers are and where a lot more of the resources are, travel and transportation was a challenge, especially in the winter. And he often felt discriminated against if he was late or had to cancel kind of last minute due to weather. So again, those were other barriers that he felt a lot more in the beginning. Um, but after having more of that relationship together, we were able to kind of tell them like, don't worry about it. Continue going to these appointments. Like, we'll wait. We're aware of the weather. And I think that by opening up and talking about these types of challenges, it made people around us more aware that this is happening and people don't just live around the corner, right? They are traveling a long ways just to make sure that they have care. So that has been really great. And then lastly, another barrier was lack of services. So again, he lives in an area that's quite remote, so he didn't always have access to a home care nurse that could come in, instantly. A lot of the time, depending on demand or in weather and what and whatnot, he wasn't always being seen. So it was important that he knew how to care for his feet and knew how to do his dressings, just to make sure in the times of when there was no services that he was still doing the right thing. We also, there wasn't always consistent foot care nurses within his community, or that could take him kind of a last minute, right? So sometimes it's contracted staff that may come in, or again, due to weather, they weren't always coming in, they were only coming in maybe just once a month. So for any reason, if where that foot care nurse couldn't come in, maybe wouldn't be seen for up to 2 months, right? So 8-ish weeks. So again, the lack of services has become and remains an issue as well. And then lastly, there's always a long wait list sometimes, right? When it comes to our diabetic nurse educators or dietitians or even the services for offloading. So again, as much as we always have good intentions, sometimes we have to wait and we're not always able to support our clients in a timely fashion. So these are some of the barriers. So I just want to say thank you for everyone for attending and listening to our story, but also a big chimajigwich to Mr. White Loon for sharing his story and his clinical images, because that took a lot of bravery and we're very thankful for that. So thank you, Miigwech.
Thank you so much, Josée. Can you hear me? Can I just get a thumbs up? Awesome. So my name is Amanda Sowiak. I live in Pincher Creek, Alberta, and I work for the Blood Tribe. And I would like to recognize that I live and work in the traditional territories of the Nitsitpi. Oh my goodness, I almost had it. Nitsitapi, which is the Blackfoot Confederacy, including Siksika, Piikani, and Kaina, also Kainai, but I've heard two different pronunciations of it. The Tsuut'ina Nation, Stoney Nakoda Nations, as well as the traditional lands of the Métis Nation of Alberta Region 3, honoring their stewardship and honoring the history, often referencing as Treaty 7 and serving as a step towards reconciliation and a deeper connection with Indigenous peoples. So on the screen here, you can see an image of Chief Mountain, and I like to have this in slides when I'm presenting about peoples that I work with, because when we are anywhere in Blackfoot territory, I look towards Chief Mountain. If I can see Chief Mountain, I am on Blackfoot territory, which is special. And next slide, please. So I'd like to introduce you to Buzz. And Buzz has provided me permission not only to provide his images, but his name. He is a very open, loving man, and you can see him there happy with part of his home care team and myself on the bottom there. So who is Buzz? He's an Indigenous man in his 60s. He's diabetic. He lives in a rural community with his wife, grandson, and stepson. He's very active in his community, so he works for Wellness as a mental health support worker. Wellness is a wonderful option that we have in our community to support our peoples who are having any issues with mental health or just need a little more support. He also is a hunting guide. He's retired from the tribal police, and he's a member of multiple cultural significant groups and Blackfoot practices, cultural practices. So he's very involved in his community, and he loves to make people laugh. You always know that Buzz is in the building when everybody is laughing. Next slide, please. So what's Buzz's story? So you can see in here, we've got some images. So he went out scouting. Like I said, he's a hunting guide. So he went out scouting, which means he's looking for animals to help the people he's taking out hunting. And he got home later that day, pulled off his boot, and he noticed it was full of blood. So as you can tell already, he has neuropathy from his diabetes. You can actually see the nail in his boot. He's provided me with this picture that he took after he took off his boot. He cleansed the area, but quickly started to show signs of an infection. So he went to his doctor, as we would expect. And while he was there, they looked at it, said, okay, let's get you some on antibiotics and go home. So he went home, but things got worse, and they got worse fairly quickly. He was later sent to the hospital and was told that he needed an amputation for necrotizing fasciitis. Next slide. So you can only imagine how he's feeling. He's a guide, he's very involved in his community, and now he's about to lose his leg. So he was very nervous, he was scared, he was depressed, and he tells his story about sitting on the stretcher, and he's about to move from the stretcher onto the surgical table. And he can see the surgeon has pulled away the team, and they're having a discussion. And that was probably one of the most important discussions of his life, because they decided that there was hope and that he had enough circulation that it was worth waiting, and the surgery was canceled. He was really excited, but very nervous. So while he was in the hospital, they were doing everything they could to try and save this foot because they had hope, right? And they had tried standard vac, but it wasn't working. And part of the reason is because of the location of that wound. They were having a lot of difficulties with it. He had transferred from one of the larger hospitals in our area to a smaller community. They continued to try and weren't having any success. So they said, there's not much more that we can do here. Let's just have him go home to his home community with home care and see what they can do to try and help. So he was discharged home. Next slide. So this is what he was discharged home with. So this was Valentine's Day, and I'll never forget it. It was the first time I met him on Valentine's Day, and this is what I walked into. So the home care nurse had called me and said, hey, I need help. So the referral was made to home care, and thankful it was during the week, because there's no home care on the weekends and holidays and after hours in our community. So he was seen fairly quickly, which is good. However, there wasn't a lot of information that was sent home with him, just the basics. So the nurse walked in somewhat blind. She didn't know what medications he was on. She didn't yet know what wound supplies were needed. So she showed up and called me. I made it over there to his house and asked him, okay, let's go through your medications. He wasn't on any antibiotics. So they had sent him home after being on IV and oral antibiotics in the hospital. Somehow there was a disconnect and he was sent home with nothing. Obviously, we still have some infection going on. So I connected with the doctor and we got him on some antibiotics immediately. I worked with the home care nurse and we came up with a plan with how to treat this wound. But the home care nurse was really kind of scared because she didn't know what to bring, what she had. So we've tried many things on Buzz with great success, as you can tell from the next slide. Next. Thank you. we've tried many things and had a lot of forward and backs. You can see we have a happy ending, but the story's not done, which I'll tell you a little bit more about. But due to having me there with debridement skills, so as an NSWOC on the reserve, we were able to provide advanced wound care, and that provided for a positive outcome for him. If I wasn't here, I don't know if the outcome would have been the same. And Buzz says the same thing. Without those skills and having the ability to provide that support to the home care team. Unfortunately, Buzz has had lots of ups and downs, and he's the first to admit that he makes mistakes, as all of our clients, and we all do. If you go to the next slide, we'll talk about some of the things that we have gone through with him and some of the barriers that I've noticed and he's noticed with his care. So one of the questions that I had when I was thinking about what are the barriers to Buzz's care, why were we so quick to go for amputation? And I really am thankful to the surgeon who questioned it, but I think that this is not an isolated incident. It's not uncommon for people to end up with amputations a little bit prematurely. And something to think about and ponder, why? Is there something that we can be doing differently? One of the other things that happened was that because they were having a hard time with the VAC in the hospital, was that because of lack of resources and education, or was it something else? I think a lot of it had to do with the location of the foot, on the foot, and that the fact that the wound actually extended through the bottom of his foot into between the first and second toe. But one thing that is very clear is we don't have the traditional VAC on our community, in our community. So we do have the disposable, which is amazing, but that doesn't work for all wounds. So there is a little bit of a discrepancy between what is available on and off reserve. And we do know that by having that available, we can decrease hospital stays and hopefully heal people faster. Okay, so poor discharge communication and planning. The home care nurse, like I said, didn't have a lot of information, and that is something that is really easily fixed. And we do work on that every day with our home care and our community. We go to discharge planning, and those are things that we're doing to try and bridge that gap. But I know that this is not something that only us have had to deal with. Lots of times people are discharged. Sometimes it's quickly because of staffing and beds, and people are discharged home without realizing what's actually available in the community, or is there anybody there to even accept care? So limited resources like home care because of our hours. Another issue that we have is sometimes getting products on time. We have wonderful vendors that we can reach out to, and they do provide our care, but there seems to be a slowing of the process. For example, I ordered supplies on November 11th and didn't get them till January 5th. You can imagine that there's been a significant change in wounds when we have that amount of time. So just the timing that it can take to get our supplies can be a big barrier for care. Follow through. Now, this is not something that is just on reserve. Follow through for blood glucose control, offloading, things like that. And then there's always mishaps. And this is where Buzz has my heart and breaks my heart frequently. He had an incident where he had a hair blow dryer, and he burnt the entire top and bottom of his foot quite significantly. And we had not only his original wound, but an entire foot to heal. He also had pressure injuries because he had to mow his lawn because he didn't have anybody else available. He wears improper footwear at times. So these are not something that is just isolated, but they were some of those barriers to care with Buzz that we had to go backwards and forwards with. But eventually we did, as you saw, get forwards. I'm very sad to admit that right now we've had a little step backwards, but that's okay. We have hopes for Buzz, and he has hopes that he'll get forward again. No shows for appointments is not something that was ever an issue for Buzz. He made it to every single appointment except for one, which is not the case for a lot of clients. We're very fortunate that we have the ability to have transportation for our clients to and from appointments. That's not available everywhere. And so having that has made a huge difference for our clients to be able to make it to care, especially if the roads are things that they don't feel comfortable with. One thing that I did want to bring up here, and this wasn't an incident for Buzz, but having worked in this community for a while, I have noticed that there are sometimes incidents of lateral violence. And what I mean by that is it's small town, and this happens in all small towns, but not all of our clients necessarily have the best background. And as you can imagine, we know that we're battling a drug issue with fentanyl misuse, and we do have drug dealers in our communities, but they also need care. And it's really hard in small communities when you may be a nurse who has had a loved one die from using drugs that was given to you by somebody, and then they become your client. So that becomes a bit of an issue. And I know we all love to say that we are above that and we would definitely provide care, but in small communities, it can be very, very challenging. So just being aware that sometimes small communities come with different lateral violence and other barriers that can become an issue. Next slide. Oh, I'm going to hand off to Tina. So I just like to say thank you, and thank you to Buzz for sharing his story. I truly appreciate him sharing his images and his story as well.
Thank you very much, Amanda, and thank you, Josée and Troy and Bev, for your introductions and your presentations. I am Tina Beckerton. I am living in the community of the Caribou, North Thompson, and Chilcotin regions in the interior of British Columbia, and just wanted to share the land acknowledgement that I present before speaking. We recognize and acknowledge that we are collectively gathered on traditional, ancestral, and unceded territories of the 7 Interior Region First Nations, where we live, learn, collaborate, and work together. This region is also home to 15 chartered Métis communities. It is with humility that we continue to strengthen our relationships with First Nations, Métis, and Inuit people across the interior of British Columbia. Next slide, please. So I would like to tell Barb's story for privacy and to prevent identity of this client. I have changed the name as well as some other information about Barb to protect privacy and confidentiality. So Barb is a 35 to 40-year-old displaced several hours from her home community. She was a high-risk term pregnancy referred to a tertiary hospital. So she would have been displaced from her home community by approximately 7 hours ground travel to the tertiary facility to deliver her infant. So she is obese, had gestational diabetes, and a fetus that was large for size. She had a planned C-section, and when her little one was born, was greater than the 90th percentile on the growth chart. The baby was delivered by cesarean section, and negative pressure wound vac therapy was provided. And being displaced out of the community, she was still in hospital for a period of time, and then when discharged, her and her husband and newborn had gone to stay in a hotel in the community that she was staying. And so she would have to show up for her follow-up postpartum appointments and her wound care at the community wound clinic. And when the negative pressure wound vac therapy was discontinued, her abdominal incision dehisced. So the referral came to me when she was wanting to return closer to home. Where I work is still approximately 3 to 4 hours from her home community. And I was sought out to provide assistance as an NSWOC, being able to facilitate the negative pressure wound vac therapy and provide an initial assessment and a treatment plan for her when she arrived in my community. Again, she's still several hours from home and staying in a hotel with her husband and her newborn. So they did have to come in 3 times a week into our clinic for dressing changes and reapplication. And um, yeah, and for her to go home to her home community, there were a shortage of nurses that were trained to do negative pressure wound vac therapy. So that necessitated a longer stay, again, away from home. We did agree for her to go home on weekends. However, that 3-day stint for her to go home and return back to us again was still an extremely um, extenuating experience for all of the travel. So we arranged for one of the nurses that was traveling through on her way through to Barb's home community and recommended and asked to come into our wound clinic so that we could teach negative pressure wound vac therapy to the nurse. So the nurse had never provided negative pressure wound vac therapy. So on a very, very short, brief visit, I was able to facilitate the teaching on how to initiate the wound care. This had been my second or third visit with Barb, and then we were able to allow her to return home. So it was a short time after she returned home. She had come back to us the following week and indicated she did not want to continue with negative pressure wound vac therapy any longer. It was too much work. It was too stressful. She was carrying this wound vac around with her and her newborn and still having to leave the home to go out 3 times a week for dressing changes. Next slide, please. So expressing some of her barriers to care and kind of finishing up the story. During my visits with Barb, I had learned that she decided she was going to confess to me and wondering why her wound wasn't healing. And she had determined that she decided to read the label one day of her oral antibiotics and learned that she was taking only half the dosage that she was prescribed and didn't realize that. She was doing that unintentionally. So that tremendously delayed healing, and she did develop an infection that eventually did subside. So the barriers that we're experiencing here are very, very similar to my fellow NSWOCs across Canada, where we talked about the distance that individuals have to travel, the surgical incision, and whether it be a wound or a surgical incision, and then having to discontinue negative pressure wound vac therapy as per her choice and her wishes. We wanted to respect that and not tell her this is what you have to do, this is what's required, this is what's needed. So with her being so far from home and the travel back and forth, it did negatively impact her overall wellness, her overall health and well-being and satisfaction and healing and being a brand new mom. Um, it affected her mental, physical, spiritual, emotional, as well as financial burden. Hard on her for sure and her whole family. She was in a foreign environment where she had lack of privacy. When she comes into a public clinic setting, such as the clinic setting that she came to in my community, she was in a very different place, different nurses seeing her each and every time she came. Um, she did express to me at one point that she really felt frustrated because privacy was not as sacred and attended to as she felt she needed and should have received. And with that, I really reached out and I thought it's better for me to consider looking at an Indigenous navigator. So I had contacted one of our Indigenous navigators here at our facility, and I left it up to the two of them to connect and communicate with each other. But in communicating with her and getting the information together for this project, I'm quite enlightened that she did respond back to me that the Indigenous navigator with questions that I had asked regarding points and subjects, topics that we're wanting to cover this evening. And just next slide, please. So, what came through my observations, my experiences, and the Indigenous navigators' comments back to me was ensuring that we're providing patients, clients, the strictest of privacy, being culturally sensitive, and providing utmost respect towards people receiving the care in the clinic settings. So I like to look at each and every client as very special and sacred to me. I treat them as if they are my family, my loved one, with a lot of compassion and care, non-judgmental, asking and respecting what services they want and what they don't want. So that goes for anybody, but I have a real big heart for being culturally aware and sensitive and respectful, asking about their social, societal, and cultural needs and their desires to accommodate them in a meaningful, dignified way. Ask them what they need, what they would like, what they want from our help, our care, our services. Involve them and their family members in the care that we're developing and we're deciding for them, that we're going to plan this and do it together, not me telling them, this is what you need, this is what you should have, this is what I'm going to do, this is what I'm recommending. I try not to use that approach. Um, and living with and working in the client's home communities, we want to really connect them to people that are safe and familiar with them and to them. If we can allow individuals to receive the care in their own communities, then why not? So, for example, assisting the client with getting their supplies, providing them with their supplies, communicating with their home community nurses so that they're aware what the treatment plan is. Do they have these products in stock in store? Where do they get them from? How do they get them? So that was a lot of planning, but it was wonderful and just wonderful to be part of that. I drafted up a very detailed care plan and communicated with the nurses directly through email and phone and offered to contact the pharmacy. They offered to come to town and pick things up as they were driving through. So it worked out so well. And to work together, as I'm saying now, to share our knowledge, provide education, resources, and supports as needed, collaborate and communicate with one another, even though we may be coming from two complete separate entities in healthcare. I think of us as all one and the same. So the feedback personally that I got from our Indigenous navigator that I received from her is very much in line with what Josée and Amanda have indicated earlier. But one of the biggest issues in my community and their communities are, and I shouldn't say mine and theirs, it's for the care that we can offer, is the vast distances traveled. Some patients aren't made aware that the patient travel workers are available to assist them with fuel, accommodation, meals if traveling long distances for care or needing to spend time away from home overnight. Many individuals have a difficult time asking for help and they remain silent, they remain quiet. So the care teams need to provide the needed information and ask questions to close the gap to care. The Indigenous navigators and the social workers, they assist patients with attending appointments so they can provide reminders, they can provide an escort to come with the patient, they can provide transportation to get the patients to and from their appointments. Systemic barriers like hospitals and clinic settings. Patients have indicated that they feel like they are institutionalized or visiting an institution, which is especially daunting and raising a tremendous amount of anxiety, resulting in no-shows for those who have attended the residential school system. They are traumatized and to come into a sterile environment, bricks and mortar facility that's brightly lit and we're dressed in white and it's very intimidating. So some of the people will just have so much anxiety they won't come to their appointment, they won't show up. So the request is if they're not showing up, that we contact our Indigenous navigators and they can reach out to the clients and say, hey, do you need some support? Do you need some help? How do we support you to come to get the care you need? Cultural trust, when care providers change constantly. So we're changing our roles and positions and shifts. Also, the nurses that are working in the First Nations health stations, there's quite a turnover at times. So the patients will get close and used to the staff that are helping them and assisting them. Then they find next time they go back, so and so is not here anymore. So and so's left and moved on. So that kind of dampens their trust and leaves them feeling quite afraid and quite insecure. Ask for permission to include the person in the care planning prior to touching them, prior to exposing them, or to referring them on to other healthcare providers for recommended assessments, testing, and treatment or therapy. Ask them and let them know, share with them your thoughts rather than them just getting a phone call saying, hi, it's so and so, we're calling to book you an appointment. That doesn't go well with the average person, but it really truly doesn't go well with Indigenous people. Um, Social factors, a major barrier to to care includes a lack of knowledge on what FNHA covers, what their Blue Cross plans cover for individuals in terms of medical equipment and supplies. So if the care providers aren't aware of what's available to individuals and what is covered, we may really lack in recommending such a thing or offering or suggesting such a thing because we don't know. So I was personally provided with a wonderful information package from this Indigenous navigator, and it has the whole coverage package in a booklet. So I'm very thrilled that that was shared with me, and I'm very grateful. And I will be reaching out and thanking her in person for that. Again, the lack of funds and transportation, we've already covered that many times. Sometimes these folks have a lack of support in their homes to assist them with healthy choices, with eating healthy meals and selecting healthy foods and food preparation. Some of them don't have family members or visitors or friends to come and help them with that. And again, attending their follow-up appointments. Sometimes they don't have the support in their home personally to support them with that. Um, and then this is a really lovely suggestion, and I've actually heard our nurses recommend and offer to patients while they're receiving their care, would they like to listen to some drumming? We have some recorded clips of drumming. And some of them have said yes, and they have listened, and that felt very, very calming and secure for them. And some of them like to listen to music. So I'm going to keep that definitely in the back of my thoughts and think that that's something I'd love to offer in my own personal experiences. And again, just reaching out to the Indigenous patient navigators. That was something that I do believe in my own practice I need to do more of. So that's the conclusion of my presentation.
Amazing. Well, thank each of you for such wonderful presentations here. And I've been collating some notes, and I think we've touched on some of the key themes here. We talked about travel, we've talked about lots of great things. But one thing I wanted to bring up, you're mentioning the Indigenous navigators. Some people were asking as well, what has your experience been with connecting with either traditional healing, traditional medicines, and incorporating that into wound care? I'm sure. Each of you have maybe a different approach or a different experiences with dealing with that, but how does that play a role in your wound healing or in your care plans? Maybe we'll start just so I know we got a lot of people on the line. Maybe we can start with Josée since you presented first. Is that, how do you approach that?
My approach to any traditional medicines is ultimately I try it. This is another way of healing, right? So it's not only just the Western way of knowing. When my clients come in and they want to use traditional ways of other medicines or whatnot, we talk about it and we try it. And ultimately, I always try to say, let's try it for a certain amount of time, maybe let's say 2 weeks. And if this doesn't work, let's try maybe my way, or maybe not my way. Sorry, that doesn't sound very nice, but let's try like a different way of doing wound care. And then maybe together we are able to then figure out a plan together. So usually, absolutely, I don't say no. I always encourage it. And yeah, ultimately, yeah, that's my answer.
Absolutely. And Amanda, and I think Jose, in your presentation too, you mentioned trying to build that trust relationship was about we're healing this together. We're on a journey through this, right? It wasn't to trying to make someone feel bad or like they're not doing something and making them get in trouble. I can't remember if that was Jose or Amanda, you're saying that in
Mm.
your stories, but
It was
maybe
Josée.
Amanda, bring it over to you. What approach do you take? Have you had experience working with Indigenous healers before, or any other liaison potentially in helping support that process too?
Yes. So it's a very important part of my practice. I feel like when I initially start anything with my clients, I always say, you come in this room, you're the boss. I am working for you, and I will not do anything to you you don't want. You are the boss. Everybody who comes in my room gets the same spiel. And then we say, what's important to you? And is traditional medicines important? Is spirituality important to you? What does that look like? And I also will check in with them throughout the process. So if we're having challenges and we're not seeing progress as fast as maybe both of us would like, usually, I'll say to them, okay, so we've tried all of these different things that I brought forward. We're done this together. What do you think? And it's amazing when I put it in their hands and they realize I really want to hear what's your take. And I'll say, have you talked to your elders? Have you talked to your spiritual guides and people that can help you? And most of the time, I'm fortunate where I work, but they'll say, "Yeah, I have, and I would like to start a brew, or I would like to do this." And I always say, "Absolutely, let's do it." And I will even say for clients prior to putting on an occlusive dressing or something that maybe you can just tell there's a little bit of hesitation when I bring up an idea, I will say, "Are you doing anything? Do you need access to your wound? Is there something that needs to be done when I'm not with you that you're doing to
Mm.
heal yourself that you may not have shared with me? I don't need to know what it is because it may be sacred. I don't need to know all of the ingredients. I don't need to know any of that stuff because it is your body and your choice and you get to do what you want. I'm just here to help you. And if you need access, then that will change what I put on. I don't want to put a $5 dressing on or a $15 dressing on that's going to come off in 20 minutes when you leave. Let's find something that's going to work for both of us."
And I think that bridges into another big topic that we've talked about here, and I saw it in the chat. I know you've each have mentioned it, is on that travel piece. If someone has to go, in some cases, like we saw in the chat, 12 hours away, we're not going to be able to maybe have more product, more education, more opportunity to see you in the next 6 to 8 weeks or even beyond that. So, what role has education been in terms of care at home with the people who are living with you at home? I know we've talked about it quite a bit, but maybe Tina, you've experienced quite a bit of this, of course, in your case with the distance involved. But how do you see that role of education so that when they leave, we're in a situation where they can keep caring for themselves and with support they might or might not have?
Yeah, I really agree with that, Troy. And I'm just going to back up just a tiny little bit.
Hmm.
Barb's incisional wound did heal. And when I spoke to the nurse at the health station, she indicated that Barb had healed her own wound. Things happened in her life that she wasn't able to stay connected to the care team. And I believe it sounded like they were trying to reach out and they finally did connect. And she had reported that her wound was healed. So I didn't get a whole lot more detail. I've tried reaching out to her myself and have not heard back. But yes, 100% Troy. We definitely want to make sure that the teams are educated as well as the family members. And, that's just wonderful. And you just triggered some more thoughts about another client I have and a family member that joins the patient. And I just received a few requests regarding some traditional medicine and traditional healing. And I am a consultant, so I'm not always there doing the wound care myself, which I wish I was because I love it so much. But I did recommend back to the nurses that provide the treatment and the care to please have a conversation with the client and the family member and ask what their goals are because they're recommending a product. It sounds like it's purchased just with the amount of ingredients sound like they're more Western medicine, natural ingredients, but not formulated in a home, in a kitchen. It's sounding more like it's a purchased product. But this is what I'm asking the care team to now ask the client and the family member, what do you hope to achieve and how is it that you would like us to help you? What would you like from the nurses to assist you with?
Mhm.
Is it just wound care dressings that you're looking for? Because I'm a little bit not crystal clear. So really including them in the education, teaching them anything that we can, and guiding them in the right direction. If we think something, may be inhibiting healing, I would say that in a very respectful manner, but giving them their say and letting them come forward. I've had people using many, many different traditional medicines, and I can't say that I disagree.
Mhm. Well, thank you for sharing that. And I know we had, I'm just seeing the time too, wanted to touch on this question because Paula brought up some great pieces of information. Part of that education piece that we can share is also how to navigate our healthcare system from a provincial, from a territorial level too. And Paula, I was dealing with the far north quite often, it seems here as well. And I thought maybe Bev, to bring you in for a second before we go back to Amanda, I know you had your hand up too, is you're looking at something like the sharing circle, but maybe any experiences that you might be able to share from other members of the core program who are dealing in Nunavut or Northwest Territories or Yukon. I know there's obviously a very different and unique challenges that are going to take place when trying to support people in the far north, just from a logistical, from a transportation, getting supplies, etc. But maybe just if there's anything you wanted to comment on in terms of, I know Sandra and Shauna Lowe both put out their contact information, their NSWOCs in Northwest Territories to get in touch with, but anything you might want to comment on or share about that? Oh man, I think we might have just lost your audio unless mine cut out there. Could you hear? No. Oh, it looks like you're unmuted, but maybe your microphone's just not connected there. Can't hear you now. Maybe just test it a little bit on your side there. Maybe I'll go to Amanda in the meantime. Amanda, you had your hand up if you wanted to touch on what Tina was talking about just before that.
Just a little comment when it comes to educating not only your client but families. We're in a time when a lot of people have cell phones. I do find that minutes is a problem, but data usually works and being able to get on Wi-Fi. So texting with your clients, when possible, taking pictures throughout the process if you're able to print that
Mm,
out and give that to your clients so that they have pictures to follow. I have the privilege of being able to say, you can text me and Zoom me, and I will anytime, Monday through Friday, um,
mhm.
I will get back to you and we can problem solve things together. Knowing that you have a lifeline out there, especially as NSWOCs, when we have the ability to do that consultative role, I think is really important. And as home care case managers, I was a home care case manager for like 16 years before I did anything with wounds. As an NSWOC. And just having that kind of a connection with your clients to know that they can reach out and ask questions really puts them at ease.
Can
Absolutely.
you
And I
hear me
think
now?
that's that. Oh, we can hear you
Can you
now,
hear me
Bev.
now? Yeah.
Yeah.
Okay, good. Sorry about that. Technical difficulties.
All good.
What I wanted to say is, yeah, I totally agree with Amanda, and I wanted to point out too, there's NSWOCs all across Canada. So if you're not sure what your closest NSWOC is or you need help, you can always reach out to NSWOC Canada, Troy will get the emails and the messages, and he can connect you because there you go, office at nswoc.ca. Perfect. I know it is challenging, especially in those remote areas, to get product on time. NIHB, it's a great funding source, but we don't. It is challenging to get it approved and sent. So reach out to your NSWOCs. They can help you. They can navigate a little bit easier for you, knowing what is on, like Tina had said, knowing what is actually available in the different provinces. Because like Tina in BC, they have Blue Cross, so it's a little bit different funding. It's all from the federal government, but it is a little bit different. So yes, exactly. Up in the Yukon, you guys connect with your NSWOCs, reach out if you're not sure who it is. And if anybody on the call is as passionate as our core program and want to join, just again, reach out to either NSWOC or you can send an email directly to me. It's bevsmith944@gmail.com. Not too hard, but I can add you to our mailing list. We meet monthly, every second Monday of the month, and it's a fabulous group. We have a great time and we do phenomenal things. So I welcome anyone. You don't have to be NSWOC. You can be anything and everything. Just join.
Absolutely. And maybe because we're past the hour here, I think it's a good place to end off is that we're not leaving you with no routes to get connected. So follow the steps Bev mentioned there. Do scan the QR code that we sent before or look up the sharingcircle.online. Pretty much all the resources we have available is there, but you have that opportunity to add if you need to get it there. I know we get some questions about what's Bev's email again. Maybe just email office@nswoc.ca. I'm putting it in the chat here. We'll get you connected. That'll probably be the easiest way, and we'll get you connected and in touch with the core program. Josée, Amanda, Tina, Bev, this is not the end of this conversation, but it's so appreciated that you're able to share some amazing cases and in most cases some very good results, but it doesn't mean that the barriers aren't still there. So it's been great to see all the positive comments of people. Yes, I agreeing that they're seeing the same barriers. It's good to see some shared experiences and that we're all working together to find better ways to be educated, to provide better care. So keep doing what you're doing. I hope this serves as inspiration as much as it is education. And we hope to do another one like this again soon. So thank all three of you for your expertise and your time. We will definitely see you soon, I'm sure.
Thanks, everyone.